I'm really technologically challenged here, so just give me a moment here. Okay, there we go. So I'm very happy to be here. My name is Dr. Sabur. I'm a respirologist and a TB subspecialist, and I practice in Toronto at two different hospitals and two different TB programs. And so I have prepared this talk today, and I hope that it's useful and helpful for all of you. And at the end, there should be time for us to have some time for discussion and questions. The objectives, hang on, I'm just going to minimize this side screen. There we go. The objectives of today's talk are to review the epidemiology and the pathogenesis of TB. We'll spend some time discussing the difference between latent disease and active disease and review risk factors for progression from one to the next. I'm going to show you some x-rays and we'll talk about the radiographic features of active TB, and then we'll talk a little bit about diagnosis. We'll review the management of both latent and active TB, and we'll talk a little bit about some of the common side effects you might encounter with patients who are on treatment. There we go. I have no disclosures. So I wanted to start with the land acknowledgement, understanding that we're all on different territories. And as I was, making this talk and thinking about what a land acknowledgement means to me personally, I thought about my own family history, and I come from a family that left a place that was politically unstable and plagued by war, and we found refuge in this country, and I'm very grateful to inhabit this land. But as I was, making this talk, it kind of occurred to me that it felt sort of disingenuous to do a land acknowledgement and then follow it with a talk about tuberculosis, a disease that has really ravaged so many First Nations people in this country. And so I decided to do another kind of acknowledgement, and please forgive me if this is the wrong thing to do. I hope it isn't, but I decided to do an acknowledgement about the relationship between TB and Indigenous populations in this country. And so I would like to acknowledge the role of colonization in TB and Indigenous populations and how this plays an ongoing role in TB care delivery in this country. I would like to acknowledge the individual and systemic racism that is so pervasive in our healthcare system and that continues to impact TB care. And I would like to acknowledge the very dark history between Indigenous populations and tuberculosis in the residential school system and outside of it. Now, I'm just a clinician. I don't have answers to how to tackle these problems or how to solve some of these really deep-rooted issues, but I thought it was important for us to state them and acknowledge them before I move on with the remainder of the talk. I usually start every talk on TB with this slide, which shows the global burden of tuberculosis. This is from the Global TB report put out by the WHO every year. This is from the 2021 report. And you can see on here that there are dark countries that indicate high TB incidence, and then the lighter ones. And Canada, of course, falls into the low TB incidence range. But I think it's important for us we will talk a little bit about this further, but if we look at a map of Canada and we look at subpopulations, we'll see a very different story. But just as a kind of global picture, the WHO estimates that about 10 million people fell ill with TB in 2020, and that there were about 1.5 million TB deaths, which is really quite an astounding statistic considering this is a disease that has been present since the 1800s, and we've had a cure for it since the mid-1950s. When we look at TB rates in Canada, we can see that there has been a steady decline in both incidence and mortality, starting around about 1950, and this is when effective chemotherapy became available. But when we look at subpopulations, we'll see a very different story. And so while the incidence of TB in the overall Canadian population is about 4 per 100,000, we can see here that in the Inuit population, the incidence is much higher, around 70 per 100,000, and that's actually down from 250 per 100,000 in 2012. In First Nations on reserve populations, the incidence is about 20 per 100,000. And in the foreign-born, it's about 15 per 100,000. So there's a significant difference when we look at subpopulations. In terms of raw numbers, this is old data from the old version of the standards. But when we look at just raw numbers of TB in Canada, we see that the highest number of cases is in Ontario, and that really reflects immigration patterns in this country. It always kind of blows my mind that I am still showing this slide in 2022. These are the top causes of death worldwide from data from 2019. And you can see that tuberculosis is on this list. And in fact, prior to COVID-19, tuberculosis was the leading cause of death from an infectious agent. Now, when we look at the natural history of tuberculosis, contrary to perhaps how tuberculosis is perceived, TB is actually not highly infectious. An infection with TB infrequently leads to symptomatic disease. Most patients who are exposed to tuberculosis will either clear the infection or they will develop asymptomatic latent infection. And it is really a minority of cases that will go on to develop active disease. And we'll talk about this a little bit further later on in the talk. The human host is the only natural reservoir for TB, and transmission occurs through ongoing, persistent, close person-to-person transmission. So that is close contact with someone who is coughing, singing, laughing, talking. They will aerosolize the tuberculosis, and these small aerosolized droplets can remain suspended in the air for several hours, and they are inhaled into the lungs, and that is how infection becomes established. But the probability of transmission will vary and depends on a number of different factors. So the first factor is what the bacterial burden is of the person who's infectious. So people who have cavitary disease, people who have high smear positivity, or who have laryngeal or upper airway involvement, those people tend to be more infectious and therefore have a higher probability of transmitting TB. The amount of symptoms that the person displays, so someone who is coughing a lot is more likely to create aerosols that can then spread TB. And then proximity and duration of exposure. So usually it's close household contact. So people who are sharing a sleeping space or who are eating in close proximity to one another. And then of course, environmental factors like poor ventilation or crowding. And then delay in diagnosis is a risk factor for increasing transmission, just because the infectious person is then in around their contacts for a longer period of time. This is a graphic looking at the pathogenesis of TB. So the TB organisms are inhaled into the lungs, and they are taken up by alveolar macrophages. Some people with very robust immune systems will just clear them at this stage. But the unlucky patient will have the TB organism take over the alveolar macrophage and start replicating inside the alveolar macrophage. The macrophage then gains access into the interstitium and launches this immune response. So recruitment of other cells, dendritic cells, monocytes, these cells will get recruited. They'll take up the TB organism and transport them to a pulmonary lymph node, where the immune system is then primed and antibodies are formed. And most people, again, if you get to this stage, then most people, their immune system will kind of activate and it will wall off the TB in what we call a granuloma. And the granuloma is thought to be a host mechanism to protect us from developing active disease. The granuloma kind of walls off the infection. But what can happen later on, and this can happen months, years, decades, even later, if something disrupts this granuloma, so whether it's a disruption in immune function or something else, the bacteria can start to replicate inside the granuloma. And ironically, although this is a host defense mechanism, the micro environment of the granuloma is actually a very good environment for TB to replicate in. And so the TB can then replicate within this granuloma. The granuloma then becomes disrupted and the TB disseminates into the remainder of the body. And this is represented here. And that's how we develop active disease. So this graphic just shows different outcomes of infection with TB. So this person here inhaled the organism into their lungs, their immune system cleared it, and they don't have any TB. This person here inhaled the TB into their lungs, the immune system was primed, and here this little red spot is kind of representing a granuloma. So the pulmonary lymph node has activated, antibodies have been formed, and a granuloma is created. And this person here has latent TB infection. This person here has got fulminant active disease. The TB are replicating in their lungs. When they cough, they are aerosolizing TB. This person is infectious and symptomatic. This person here has what we call subclinical TB, and this is a state that occurs between latent and active disease. And this is basically a state where the TB are replicating, but the person does not have symptoms yet. And we believe that there is some movement between these three states of infection, and I'm going to talk about that a little bit further. So here's another graphic demonstrating the different spectrum of TB infection. So these people here have had an immune response to the TB organism and have cleared the infection. Okay, now you'll notice here, this person with the cell-mediated immune response will still have positive testing for latent TB, even though they've cleared the infection. And that is because the tests that we use for latent TB are immune-related assays, and your immune system will still recognize the antigen from the TST and the IGRA. But this person has actually cleared the infection. This person has got latent TB, and this is represented here by this granuloma. Their LTBI testing, TST and IGRA, will be positive, but their sputum cultures will be negative and they have no symptoms. This person here has active disease. The TB organisms are actively replicating in the lungs. They may or may not have positive latent TB testing, but they will have positive sputa. They're symptomatic and they are infectious. And this person here is subclinical, meaning that they don't have symptoms. They may have no symptoms or very mild symptoms, but their sputum is intermittently positive. And so here's another graphic showing these different pathways of progression. So here's where the person is infected with TB. These are the people who have eliminated the TB. These people are the ones who develop primary TB. Primary TB is relatively uncommon and tends to occur in children or in people who are immune suppressed for some reason. Most people, if the organism persists in their body, they go into this latent state. And this state can last, like I said, for months, years, decades, even longer. This person here has rapid reactivation. So this is what we call post-primary TB. And these are the people that we are trying to usually target with our contact tracing, household contacts that we give LTBI therapy to. We are trying to avoid this rapid reactivation. And these are people who are reactivating much later in life. Often these are patients who are elderly, or we see it a lot in the immigrant population, people who have been remotely infected with TB in their home country and then for whatever reason will reactivate later in life. And these here are the subclinical patients, which are very tricky to identify because they will cycle between active and inactive disease. Of note, you can see that it is possible to eliminate the infection at any stage, early or late. And we don't have a good understanding of when or how this elimination occurs. Now, when we look at risk factors for TB reactivation, you can see here that there's a long list of things that might promote the switch from latent to active TB, but most of them have to do with immune function. And so HIV is a big risk factor for TB reactivation. Immune suppressing medications, so TNF-alpha inhibitors or other types of chemotherapies, corticosteroids, these will increase the risk of TB reactivating from latent to active. And then there are other states of relative immune suppression that we see in people with comorbid disease, so chronic renal failure, particularly patients on dialysis, diabetes, and then of course the environmental or sort of more social factors like poor undernourishment, smoking, alcohol use. These things can increase the risk of TB reactivation. Now here's an X-ray of someone with latent TB. This person is asymptomatic. Their X-ray is normal, but I hope you can appreciate here that when we look at the redacted views, you can see these kind of dark spots here. These are calcified granulomas, and this is how we can sometimes identify latent TB. It's hard to see on X-rays, and many radiologists may not pick them up because they can be very subtle. But oftentimes we'll see these sort of subtle signs in people with latent infection. Latent tuberculosis is diagnosed by tuberculin skin test or interferon gamma release assay. This is straight out of the Canadian TB standards, and I assume that many or most of you are familiar with, probably better than me actually, at planting and reading tuberculin skin tests and knowing what the cutoffs are or for when to consider them positive. But we sometimes will use interferon gamma release assay or IGRA tests. I'm not sure if any of you are using this test. We tend to use it in the foreign-born population who have received BCG vaccination in their home countries. It's helpful because the TST can be falsely positive in the setting of remote BCG vaccination. And this is a blood test that basically is a test looking at cell-mediated immune responses and measures T-cell release of interferon gamma following stimulation by antigens that are specific to TB and does not cross-react in the same way with the BCG vaccine. Treatment of LTBI, we usually will use the previous old first-line regimen was 6 to 9 months of isoniazid. More recently, there's been a large study looking at 4 months of rifampin, and so this is more the standard of care that we're using in our clinics. The first-line regimen in the Canadian standards is rifapentine and isoniazid, which is a weekly dose of therapy for 12 doses. I find it kind of ironic that this is the first-line regimen when rifapentine is actually not widely available in Canada. We can get it in certain contexts, but I don't know if you guys have better access to it than we do, but we use relatively a little rifapentine and isoniazid and much more rifampin. I just see someone, oh, somebody said many of our communities still get BCG vaccine too. That's right. So the interferon gamma release will be, we've been able to access it for our recent latent cases for the rifapentine and isoniazid. Excellent. It's very difficult for us to get rifapentine, and so you know, perhaps you guys probably have more experience with it honestly than I do. I've only used it in a handful of cases because it's very difficult for us to get here. In terms of active tuberculosis, the classic clinical features are cough that's usually persistent over a number of weeks or months, sputum production. Some people will develop hemoptysis or cough up blood. I would say that is more of a late sign, like usually when the active TB has been present for some time. But I would say that almost every single patient will have lost weight. It seems to be a very common symptom, even the ones that are feeling well. Will often notice that their appetite has been low and that they're losing weight. And then, of course, the systemic symptoms like fevers, chills, sweats at night. On the X-ray, we tend to see fibrinodular infiltrates or cavities, and they tend to be in the upper lobes of the lung or superior segments of the lower lobes. So I've got some examples here of X-rays of active TB cases, and these are all patients that I've seen in the last month. So this is a patient here with you can see this arrow pointing at this nice, large, thick-walled cavity in the upper portion of the right lung. There's also some associated volume loss. You might see that reported, that the hyla here is pulled up. So there's volume loss on the right, and then this kind of fibrinodular disease and a cavity. And this is a very classic X-ray for tuberculosis, for active TB. This is someone with a cavity. It looks like it's in the mid portion of the lung, but if we had a lateral, which unfortunately this was a portable, so this person did not have a lateral, but we would see that it's actually in the upper portion of the lower lobe. And this is a very common place where TB loves to proliferate, in the apices of the upper lobes and in the superior segments of the lower lobes. And you can see here on the redacted view that this cavity really pops out. This is a person with HIV co-infection, and I couldn't figure out how to get rid of these markers that the radiologist has put here, but you can see that there are these kind of bilateral scattered nodular opacities, but there's also this fibrinodular infiltrate in the upper lobes, and then this really large thick-walled cavity in the right upper lobe, very classic for TB. This is a person who we are treating right now for TB, who actually developed TB after getting COVID and receiving steroids for COVID infection. So this is the pre X-ray. This person has leads on their chest. This, I think, was taken in the emergency room when they presented with their COVID infection, and then got quite sick from COVID. And then it took a long time for the TB to get diagnosed. But you can see here between the pre and post X-rays that I hope you can appreciate. There are these new infiltrates in the upper lobe, these sort of streaky infiltrates, and new volume loss. And this person, I believe, had a bronchoscopy, and that's how the TB was diagnosed. And this is a young girl that I just admitted to our TB unit over the Christmas holidays. She's a student from India and had months of weakness, progressive weight loss, cough. She's 30 kilograms. And you can see here just very extensive upper lobe infiltrates and cavities. You can see cavities on the lateral projection. She's got very extensive disease. So the diagnosis of TB, we use different modalities, including X-ray, sometimes CT scanning, but the real, like the bulk of diagnosis occurs through sputum testing. And so we're going to talk a little bit about that. This is a picture showing acid-fast bacilli that the microbiologist will look for. And so these are the TB acid-fast bacilli. And so basically they put this, they make the slide, they put the stain on the slide, and then they wash it with acid. And the TB organisms have the ability to hold on to the acid. And that's why they're called acid-fast. I'm sorry for this. I know it's a very busy slide, but I wanted to kind of review the different types of assays that we would use for sputum testing. So when we collect a sputum from a patient, it goes to the lab, and the lab will first do microscopy. Oops, where are we here? They'll do microscopy here. Well, they'll look for the TB organisms. If they see acid-fast bacilli, they will do PCR testing to confirm that it's actually tuberculosis and not a non-tuberculous mycobacteria. I don't know how much NTM you guys see in your communities, but I can say that in Southern Ontario, we see piles and piles of NTM. And so the lab will automatically do PCR testing. Here it says expert. We here in Toronto don't use Gene Expert. I suspect that some of you probably do have access. Your labs have access to Gene Expert testing, but regardless, it's some form of PCR testing to identify that it's the TB organism. And then once they identify that it's TB, then the clinician gets notified, public health is notified, and the patient gets notified to isolate. And then the lab goes on to do culture and drug susceptibility testing. And so basically what they do is they then incubate the slide and wait for the TB to grow. And the culture is really important, number one, for confirmation that it's TB that's relevant, that needs treatment, but also because without the culture, we cannot get drug susceptibility testing. And I won't go into the specifics of DST testing. I think it's maybe beyond the scope of this talk, but I can answer some questions if you have any about them afterwards. We have Gene Expert at hospital in Sioux Lookout. Wow, that's amazing. Current outbreak, we use it for some outpatient contacts. That's incredible. I mean, I actually think it's probably almost more appropriate for Expert to be available to you than to us here in the city, because it provides very accurate and very rapid testing with very relatively little lab technical capability. And so I think that's really why the Gene Expert is such a powerful tool for diagnosis of TB. Here. Now, in terms of treatment of TB, the TB organism is it's a tricky organism. And the reason that TB treatment is so difficult is because there are different growth capabilities of the TB organisms. So in one patient, you will see different growth capabilities. You'll see the rapidly multiplying organisms. Usually those are the ones that we see inside cavities. They're high in number, they replicate very quickly, but they also usually are killed very quickly by the TB treatment. Then you will see another population of slow growing organisms. And then there are the semi-dormant organisms, like the kind that we see inside of the granulomas. And these ones are very difficult to kill because they grow very slowly. And this is really why TB treatment is so long. This is a graph showing the number of bacteria in the sputum in a single patient on treatment. And so you can see here, the blue are the actively replicating organisms, and the Red ones are the semi-dormant or slow-growing ones. And you can see that when we start TB treatment, there's really like a very rapid logarithmic drop in the number of organisms. But then these organisms will persist through treatment, and it takes a long time for them to be completely eliminated. But this is really the rationale for, in the new standards, they've reduced the time for isolation of patients, which is appropriate because it's really these ones that cause patients to be infectious. And our TB therapy in most patients is highly effective, and it works very quickly in eliminating those rapid growers, the ones that cause the patient to be really infectious. This is straight out of the TB standards. Probably you'll all be familiar with this, but this is the preferred regimen for drug-susceptible TB. We start out with 4 drugs: isoniazid, rifampin, pyrazinamide, and ethambutol. And this is when we don't yet know the drug susceptibility. Once we know that it's a fully susceptible organism, we'll drop the ethambutol. This is kind of like an insurance drug, just in case it ends up being INH resistant or resistant in any other way. And so once we know that it's a fully sensitive drug, we drop the ethambutol, and then it's isoniazid, rifampin, and pyrazinamide daily. And then after the intensive phase of therapy, which is usually 2 months long in most patients, we'll stop the pyrazinamide, and then the patient remains on isoniazid and rifampin. And pyrazinamide is an excellent drug for TB, but it's very bacteriostatic. It works very well for those rapid growers. It also tends to be quite toxic. Like out of the first-line TB drugs, the pyrazinamide is generally the one that people will run into problems with. And so we drop it usually after the intensive phase of therapy, and then continue the other 2 for the remainder of the treatment. In terms of adverse events, I would say out of all of the TB medications, like I mentioned, pyrazinamide tends to be the one that will cause the most problems. Many people will develop arthralgias or joint pains. If they have gout, pyrazinamide can flare their gout. It's the most hepatotoxic of all the TB medications, and it's commonly the culprit drug when we see a rise in liver enzymes, and it can cause rash and a number of other things. So we monitor with liver enzymes. I have to admit that we don't normally monitor with uric acid routinely unless the patient has got a history of gout, but it's something that we kind of think about when we see our patients in follow-up. Rifampin can cause rash or pruritus sometimes. It can cause GI upset, usually nausea. It can cause liver enzyme disruptions. It can cause bone marrow suppression, so anemia, thrombocytopenia. And then the other problem with rifampin that many of you may be aware of is that it interacts with lots of different drugs. And so sometimes we're limited in its using it, or we have to adjust people's other medications in order to be able to use rifampin. And then isoniazid can cause hepatitis or hepatotoxicity. It also will commonly cause peripheral neuropathy, and then GI intolerance, usually in the form of diarrhea. And then ethambutol, for the people that end up being on it for a long period of time, like for the full duration of therapy, it can cause optic neuritis. And oftentimes it will happen later on in treatment. So you have to be very careful about asking patients for this and monitoring their acuity and their color vision testing. When it occurs, it happens very quickly, and it's usually irreversible. So we have a low threshold to, if we can have them assessed by ophthalmology, we do that, but oftentimes we just drop the drug. So in terms of management of common side effects, when people have a rise in their liver enzymes, it's very difficult to know what the culprit drug is. Oftentimes, if it's a mild elevation, we will persist with treatment and watch and see what happens. There's this thing called hepatic adaptation that happens in some patients where the liver enzymes will transiently rise a little bit and then come back down. So we try not to panic if the liver enzymes are sort of 2 times above upper limit of normal, but I'll often bring them back to clinic sooner and have the blood work repeated within a week or 2 weeks rather than waiting the full 4 weeks. But if they go up significantly, then we will hold all the medications, and then we usually give the liver some time to recover, wait until the transaminases have returned down closer to normal, and then we reintroduce drugs sequentially. And because pyrazinamide is most commonly the culprit drug, and by that time we usually have drug susceptibility testing, meaning we don't really need ethambutol, we'll usually start with rifampin and then add in the isoniazid, and then just usually pyrazinamide is the culprit drug, and we don't need it. We just extend the treatment to 9 months without pyrazinamide. And so most of the time we can get away with that. In terms of GI intolerance, there are some tricks you can try. We always tell patients to take the medications on an empty stomach because it's best for absorption, but it's hard to take so many medications on a completely empty stomach. And so if they're having nausea or feeling really sick, I'll tell them to take it with a small amount of food, or sometimes I'll suggest to them that they have breakfast and then wait 2 hours and then take their TB medication, so that they're not taking it first thing in the morning on a completely empty stomach. Sometimes that makes it a bit more tolerable. Public health doesn't love this suggestion, but sometimes it does help to split the doses. It makes it harder for DOT, but sometimes it makes it more tolerable, especially for people who are on 4 drugs. It's just such a high pill burden. It can be a little bit easier to manage by splitting doses. We'll often give antiemetics and suggest that patients take them 30 minutes prior to taking their TB medications. We always start with Gravol because it's more available and less expensive, but sometimes people will need something stronger like Zofran, and it can really help tolerability. And then, of course, there are some people who just, lose weight and feel awful. And so when that happens, we usually hold their medications, give them a break for a couple of days, and then reintroduce sequentially to try and identify which is the culprit medication. For rash and pruritus, if it's mild, I would say, a lot of patients will get pruritus, but no rash. And so for those people, usually you can get away with antihistamines or just topical. I find that, I don't know if this is really a thing, but it seems to me that many or most patients, they get a lot of skin dryness when they're on the TB medications. And so I recommend that they, just get a big bottle of like a thick lotion like Cerave or Cetaphil or one of those. And, I get them to use it twice a day. And sometimes that is enough to help with the pruritus. But if there's an actual rash, then sometimes they need antihistamines. Or of course, if it's blistering, if it's extensive, or if it looks like urticaria, there's mucous membrane involvement, then we have to stop the medications. And then it's the same process that we wait for the rash to clear and then we reintroduce. There are a lot of patients that if they have acne, their acne will flare with isoniazid. I've never really had to stop somebody's INH because of acne, but it is distressing to some of them. And sometimes we'll get their acne treated with something else. Peripheral neuropathy is a common side effect to the TB medications, and it's almost always related to isoniazid. And it's more likely to occur in patients who have risk factors for neuropathy, if they have diabetes, if they have hypothyroidism, if they're pregnant, if they're malnourished or using alcohol. And so I've noticed here in Ontario, I used to practice in Alberta, and we would only give B6 to patients who had risk factors, but here everybody gets it, at least 25 milligrams. And I don't think that's wrong to do, but we'll often increase it. If they have neuropathy, we'll increase the pyridoxine up to 100 milligrams. And then if it becomes severe, then we sometimes have to stop the INH. And it does typically get better just with time after stopping the drug. And so I'm going to end there. I hope that that was helpful for all of you, and I'm happy to answer any questions that any of you might have. Where are we here? I'm trying to make this big again. Any questions from anyone? Maybe I'll stop sharing here.
Okay, I'm just going to take it off mute for a minute. Sorry, I was really far away there. I'm going to take it off mute for a minute just to, I see we have I'm just looking at the participant list here. Anything to add or any questions?
I welcome any comments. I honestly don't, I didn't really know what all of your particular practices are. If you have any specific questions, I'm very happy to answer them, or any comments are also welcome.
Okay, I don't hear any questions. I guess that is it for today. I'm just posting the evaluation. Thank you for the presentation.
Thank you for having me. I hope that it was helpful and informative and relevant for all of you. Um, I think that you guys have a much more challenging environment to practice in with much less support. I really respect all that you guys do with your patients.
Just because I see that a lot of the attendees are nurses who sort of do a lot of the sort of follow up with these
Yeah,
patients and things like that. I'm just wondering, like you talked about medications and sort of ways to help and sort of some skincare stuff. Any other sort of care pieces just to help people get through from the start to the end of treatment that
I
you
think
could
that
share?
it requires a lot of I try to just like hear people out because a lot of times and reassure them that most of the time, most of the side effects will occur early and the body does seem to get used to the drugs. Like, I would say that, even the pruritus and stuff like that, most of the time, if you stick it out, you feel better. A lot of patients complain of fatigue at the beginning. Once they kind of get used to the medications, it does get better. So I provide some reassurance in that regard. And then I also reassure them that, it gets better over time just because the pill burden decreases. And so they kind of have that to look forward to, which makes it sort of easier. I honestly don't, it's hard. It's a lot of drugs to take for a terribly long time. And I just hope that there are trials underway looking at shorter courses of treatment for some patients. It's kind of unbelievable that we're still using the same treatment that we used in like 1955 for TB. There has to be a better way to treat this disease, and I think that finally we are starting to make some progress, but for now we're stuck with this 6 months minimum, and it's a long time and it's hard to take. So somebody here said once latent has a full treatment course, are they considered cured or can it reactivate? That's an excellent question. And the truthful answer is we don't know. We believe that that the majority of patients should be cured with that duration of treatment, but there's no test of cure. And the TST and the IGRAs will be persistently positive. So there's no way to genuinely know for sure. When we look at, large epidemiological studies looking at risk of TB after LTBI, I tell patients that it is fairly effective. Like, it's, somewhere between 90 and 95% of patients will not get TB reactivation again. But that said, you can get reinfected. Absolutely. It's not very common because TB is not maybe very common, but it absolutely does happen. And where I did my sub-fellowship training in tuberculosis in South Africa, TB is very common and lots of people will get treated multiple times in their life for TB, even after being treated for latent TB. So it can happen. But it's relatively rare. And then of course there's the issue of if you treat somebody with 9 months of isoniazid, but actually they had INH resistant latent TB, then the INH won't work. So there's that issue also, but that's a relatively uncommon situation. Someone here says, once medications are started, how long are patients considered infectious? So that's another excellent question. And up until, very recently, at least in Ontario, yeah, sure, I'll give you my email. I'll just put it in here. So according to public health guidelines in Ontario, at least, up until very recently, patients were considered infectious until they were smear negative. And that can sometimes take a long time because people who have a high burden of disease can be smear positive for a long time, even though they're not really infectious. Their sputum smear can be positive. Sometimes when you collect the sputum, it's dead organisms, not live organisms that you're collecting. Sometimes we would see non-tuberculous mycobacteria co-infection or contamination. And so those people would be smear positive for a very long time. And so in the most recent version of the Canadian standards, and I think that most public health regions are adjusting their policies to reflect the changes in the standards. Now the guidance is that the patient should be on, if they are smear negative, they should be on isolation for a minimum of 2 weeks of effective therapy. And if they are smear positive, they should be on isolation for a minimum of 4 weeks of effective therapy, but they also should demonstrate some clinical improvement. And so, for most of our patients now, even the ones with very high smear burden, we're able to take them off of isolation after 4 weeks of good treatment. It's different for drug-resistant TB, but for most patients, 4 weeks of effective therapy for those who are smear positive. Are there criteria for people offered the BCG vaccine? Who is it that gets these vaccines? That's an excellent question, and I honestly don't know the answer to it because we can't get it. I actually tried to get my daughter BCG vaccinated. She was born in Calgary and I couldn't get it. So I don't even know in which communities it's offered or available. I imagine that it's in places that are considered very high incidence. So probably perhaps in some of the Inuit communities where the incidence is extremely high. But I don't know. How do we know if we have drug resistance?
Sorry,
Yeah.
if you don't mind me
Oh, yeah,
interrupting,
please.
I can answer that question.
Thank
It's
you. Yeah, I would love to.
hi, it's Lisa Letkeman. I'm one of the family docs in the region. And so up until probably 5 years ago, all of the babies in all of our communities were offered BCG vaccine. Given many communities hadn't had active cases for a while, there was basically looking at which communities still had active cases in the last X number of years. Public health came up with criteria, and so there are a few communities where it is still offered to babies, and then other communities it is not. So your best resource probably is the TB program at SLFNA. Like those nurses know everything. So I would ask them, but Marika probably has a list too of who gets it.
Thank you. The next question here is, how do we know if we have drug-resistant TB? So that's another excellent question. And we will often suspect drug-resistant TB in somebody who has been treated for TB before in the past. But really the way that we know if someone has drug-resistant TB is through drug susceptibility testing that the lab will do on every isolate. So every single isolate, the lab will culture and then do drug susceptibility testing. I would say drug-resistant TB is relatively uncommon in Canada. Like we see quite a bit of INH resistant in some of our patients who come from different parts of Southeast Asia. So like it's fairly high rates of INH resistance in the Philippines, in India. And so overall in Canada, our rate of INH resistance is about 10% of cases, but that is really mostly in the foreign-born. Oh, interesting. So it's babies born in Winnipeg get BCG, but it's not administered in nursing stations anywhere in Ontario in the last few years. Interesting. And so I wonder, perhaps, I don't know if any of you can answer, but for latent TB, then in that case, for the people who have had BCG, is there funding for IGRA testing?
Because this is a huge issue because almost everyone over the age of 5 has been BCG vaccinated. And so it becomes a giant thing to get somebody to fund it every time we have like a mini outbreak.
We have the same
and so
problem.
We do have a small number of cartridges apparently that have been paid for by SLFNA TB program at the hospital and to look out right now. Again, the TB program and Dr. Schreiber, our ID doctor, usually would be the ones that are ordering that.
Okay. Yeah, it's really it's a shame that IGRA testing is so limited. You know, over here, like patients have to pay for it out of pocket, and it's expensive. It costs about almost $100, so it's limiting for most. But it probably avoids, you know, testing and treatment. It would avoid treatment in some of these patients. Okay, well, I guess maybe we can wrap it up here then. I'm happy to receive comments or questions. I put my email up in the chat, and I hope that this was a helpful talk for many or all of you.
Thank you very much. We appreciate your time.
Thanks for
Thanks,
having me.
everybody. Thanks for coming and taking the time. Have a great day.
All right, bye.